Hey, y'all. I'm doing this reverb here. Let's see. Sorry about that. Oh, that should fix it. Hey, y'all. Happy Baby Friday. Betty here. And I am glad that y'all could take some time out on your Thursday to join my really, really, really good friend, Sally, and I, as we talk about multi-specialty, background and how it can help you in your healthcare career. So I want to introduce my good friend and colleague, Sally Christiansen. Hey, Sal.
Hi.
She and I have been, oh, geez, Sal, it's what, over 20 years, right? Yeah.
Close to 25 years.
Mm-hmm. Yeah. So I knew Sally when she was a super baby in the field. And I was a director at a healthcare organization where she was working under me. So kind of got her a little bit more kicked in the pants into coding and got some certification classes started with her and stuff like that. So I have known her for a very long time, and she is just a wonderful, wonderful person. She actually now lives in Iowa, and I was at the IAHEMA conference last week or week before last with Sal, and I posted some pictures up there from when I was there in Iowa. So glad to have you with us today, Sally.
Thank you.
So as people come in, y'all just, give us a shout out, let us know you're there so that we can say hey to you. And as usual, any questions that y'all have or any comments y'all want to make as we're talking, throw them up in the chat and we'll pull them in as we can and try to answer things for you. Sally, to start off, why don't you tell everybody like your kind of pathway to where you've gotten where you are now, since you are a couple decades in, but still not as many as me.
Well, I mean, I think, oh my gosh, I think it was more like a stumble into the HIM field. I can remember that it was the supervisor at the time. She said, oh, we need somebody to do data entry for coding. And, I kind of looked at her like, okay, sure, I'll help with that. And then that's when I met you, and you so graciously just kind of took me under your wing and kind of explained exactly what you did. And at that time, I was, in my early 20s. I was like, oh, okay, not really paying attention to really what you're saying. But then, I don't know, it just kind of, okay, this is interesting. I always wanted to work in the medical field, but didn't really know what I wanted to do. So when you took that opportunity to really kind of dive into what coding was about, how important documentation was and so forth, and just the behind the scenes of, that particular field, I was like, oh, this is kind of cool. And then you picked the hardest specialty to start with, cardiology, and it's been, I love cardiology to this day. It's my favorite specialty. So, so anything cardio, I love. It just kind of took off. And I think the more I was exposed to it with what we did when we worked together, and then afterwards and so forth, it just spiraled into a career that I absolutely love and enjoy. It's something new every single day. Everything, it's just so different. And it's so rewarding to kind of get the behind the scenes of what's going on in healthcare. And because healthcare is very prominent, today, everybody talks about it, and there's been so many different issues in healthcare and cyber attacks. I mean, there's just a vast topic, but I think it was just more like I challenged myself, like, okay, I like this. So let's see how much more I can absorb as a sponge.
Yeah.
go from there. So
Cool.
that's pretty much how it got started. Just a little nugget.
Yeah.
That you
Planted a seed.
Yes.
And you've done so well. I'm so proud of you.
Thank you.
You're welcome. So we have Teresa is with us again today. So hey, Teresa, and glad you're in warm Arizona. I'm in warm Florida today. We're like in the 80s, of course, and the sun is shining and my palm trees are swaying. So that always puts me in a good mood. And Sonal, hers always comes in. I don't know why, but she always comes across as LinkedIn user when I put her up. But she said she loved your Iowa AHIMA chapter because Sonal was there speaking also. So she was saying hey. And it's funny, Sheila is asking, and there's no silly questions, Sheila. She said, what's the meaning of a one-trick pony? Well, the saying usually means that someone they can do one thing, so when I put it out there as kind of a one-trick pony, what Sally came to me, we were talking about her coming on, and she said she'd like to talk about having like a multi-specialty background rather than being specialized in one specific area. So in that meaning here, that's what I meant by one trick pony, is that someone that is working in only cardiology or only dermatology. Not that there's anything wrong with that, because sometimes people find a specialty they love and they're like, that's it, I don't want to do anything else, and it works for them, and that's great. But I also wanted to talk about how being able to add different kind of things in there, especially if you're looking to do consulting work or things like that, that it could be very beneficial, to have more than one specialty kind of in your bag of tricks, so to speak. So that's kind of, what we were meaning by having this discussion today. So please, if y'all have questions, like I said, just throw them in there, and we'll get to them as we come across things. And we got another person, Christy. Oh, hey, Christy, she's in here today saying hey. So now my background for people that don't know about my my journey as it is, how I got the kind of experience in that broad base that I have, is that I was in X-ray and found out I really didn't care for it. I mean, it wasn't bad, but the touchy-feely stuff got a little bit too much for me. We had the account for Stateville, which was, a very large prison, Sally, being from Illinois in there too. And so we were just nicest people sometimes that we would have, we would go in to do someone and there would be like 3 or 4 guards around them. The guys are handcuffed and, which they have to remove and leave when you're doing their x-rays because they can't be exposed. So you're in there with these criminals that you have no idea what they did because, that would be a violation of their rights if they told you. So, it was just sometimes a little dicey. I did dead bodies. They would, we had one, probably the worst one I did was in the summer. It was like July, and they found a body in the ditch in I-80. And so they had to bring him in. Yeah, it was bad. It was just bad because they want to know, was he shot? Was he, is there, what's inside? We had a body one time, the guy had been burned in a house, brought it in, and we had to x-ray the burned body. Come to find out there were bullets in the guy. So he was shot and somebody set the house on fire to try to cover up the fact that they shot him, so it's like stuff like that where I was just like, yeah, that's more than I want to do. So I said, I'm really done. And they said, well, you have a good background. You understand terminology, you have clinic, blah, blah, blah. So we'll put you at this clinic. You can pick any clinic you want. So I went to a clinic that happened to be like 5 minutes literally from where I was living. So it was a good deal for me. So I go there and, I started into what they wanted was, to have me doing the coding for the physical therapy and for the physicians and stuff like that. So, but the best job for me came, my second job after that, I went and worked for a faculty foundation for one very large teaching hospital downtown in Chicago. And they had, at the time, 450 physicians in the faculty foundation. And so we started an abstraction program. So I helped the director like set everything up and get it working. And so what we would do is when patients got discharged from the hospital, and this was back in the day when everything was in charts, ladies and gentlemen watching. So, there was somebody that would ride a scooter. They had tunnels like underneath the street that went from the hospital over to where we were. They have all these secret little passageways and stuff, but they would pick up the charts of all the patients of the physicians in the faculty foundation, and they would bring them over to us, and we would have to code them for all the professional services that were done from the time the patient was admitted to the time they were discharged. And at first they tried to do it by specialty. So like I had endo and I had dermatology and somebody else did cardiac. But then we were like passing charts back and forth to each other, all day long. Because when you're in the hospital, of course, they're going to see multiple specialists sometimes. And so we decided instead, you would code the chart from beginning to end, no matter what. So no matter how many specialists on, no matter what they had done. So that gave me a base of everything. So you would code it no matter what. So you had to get yourself up to speed on multiple different specialties. And so I ended up, I think I've done, every specialty. Ophthalmology is still, I have to say, one of my least favorite, just because the eyeballs freak me out. I'm an organ donor, but even when I'm dead, I told them they can have everything but my eyes. You still can't touch them even when I'm dead. I can't do it. Just the thought of it freaks me out. So, but everything else, we had to do. So it gave me that knowledge base so that as I moved on from there, I really could go anywhere, and as a consultant, it really helped me because it was like, well, yes, I've done that before. And yes, I have done that before. And, so you get to be where that's very helpful in that manner because your potential, clients are many versus in that one specialty and one specialty only. Like I said, though, some people get into one specialty, they love it. That's great. For me, I liked being able to do all of those because I like looking at different stuff. Like you, Sal, probably the funnest one I did was when I did ED stuff because every single record is different. Mm-hmm. And you get some very interesting cases when you work in the ED, but other than that, so I kind of look at ED as kind of multi-specialty as it is, just because it is so different. Sometimes you're going to have accidents, sometimes it's sick, patients that have pneumonia, something, so it's always, and then you've got the really weird ones that'll come in where they have, like a bar sticking out of their shoulder or something like that. Yeah. So that was always really fun for me. Yes, Christy, ED, definitely. I thought that was a super fun one. And Jeanette is with us too. So I just want to pull Jeanette up. So, hey, Jeanette. With you, Sal, after you left from Freeport, mm-hmm. What kind of was it that kind of interest or, like me, that you had to do multiple different specialties? What was it that kind of was like, I just kind of want to look as much as I can? Was it like your curiosity of, wanting to just learn about different things?
I think it was. And I think, like you, when I left, I became a consultant and, it was, very early on. So it's kind of funny that, when I tell people that I've been virtual for, 20 years, and not working in a healthcare facility, they kind of look at me strange. I'm like, yeah, I was probably, it was a new fad, way back then. But I think I've been exposed to a wide range of clients that had so many multi-specialties, and they were not just your regular, family medicine. This is more of your really complex, transplant, very more aggressive surgeries and so forth that you wouldn't necessarily see in a local hospital. Not saying they won't perform it, but
Right.
some of those procedures are performed in a teaching facility. And I think that the interest kind of sparked me like, oh, that's kind of cool, to read and stuff like that. And, they would always ask and say, do you have experience in this specialty? And I would say, no, but I'm willing to try. I'm willing to learn. And I think it was just more like I really wanted to know. I wanted to know the ins and outs. And it wasn't just, the pro fee. I wanted to know inpatient. I wanted to know outpatient. I wanted to know every single type of coding there is and really have an understanding for it, because it's only going to make me more marketable as a person on my resume.
Yeah.
Because there isn't, there's certain, specialties that I really haven't, really dived into, but that's okay. But the other ones, people see that on my resume. It's like, oh, you have that experience. I'm like, yes, I do. And it's, and I don't tell people that all the time. It's like one of those little secrets I keep to myself, because, I only say yes unless I need to say yes. I give everybody else an opportunity, to say, no, I don't have that experience. I don't know. It's fascinating because, it's cool how the body works, and it's cool how, all the different organs work together one way or the other and so forth. So I think it's just a curiosity, like you said, was the trigger that kind of expanded my horizons in the HIM field.
Yeah, because I think, as people in our part of the healthcare field, codes change every year.
Mm-hmm.
Regulations change every week, it seems, sometimes. And so we are in our field forever learners.
Mm-hmm.
That's something if I used to, when I used to teach coding classes, the certification classes, I would get some people that were like, well, I'm black and white and I need to know what the right answer is. And I said, you are going to be so frustrated in this field that, maybe, you should look and see if this is really, really what you want to do. Because we do have some black and white things, but a lot of our stuff is in the gray area. And that's why, they make those comments and those jokes about you can take the same record and give it to 5 different coders and get 5 different answers that they can justify and they can defend, which I think makes it fascinating. But, that's the truth, so I think for a lot of us, that's why we get the way we are with these things, because you find that and you're just like, okay, well, I've got this specialty down now, what other specialty can I go and look at, or what other thing can I go and look at? And where you get people that have the multiple credentials, which is another thing I wanted to talk about, because I know you, like me, are credentialed with both AAPC and HEMA. You have your RHIA or RHAT?
I have my RHIT. I'm currently working on my RHIA.
Okay. And those are HEMA credentials.
Mm-hmm.
And then you're a CPC with AAPC.
Yes.
And for me, because I get asked a lot, who's better, AAPC or HEMA, and that can start. It's just like asking people over or under with the toilet paper. You're going to get a fight, So, to me, I say, I have both, and the reason why I have both is because when I was first starting into coding and things like that, where I worked at, nobody had ever heard of the credentials before, and it was like in the early 80s, and this billing service, I was working for a very large billing company, and they had said, hey, do you know that there's these certifications for, blah, blah, and we're like, oh, no, so they sent a couple of us to take the exam just to kind of see what was going with it and stuff like that. And since we were, doing profi stuff, we that's where we were sitting with and got our CPCs. And as I continued in my career, when I started my company, it was for business purposes, really, for me, that I was like, okay, when I talk to hospitals, they're like, I really don't recognize these AAPC credentials. They didn't know what they were. Mm-hmm. And so, and hospitals, of course, own health clinics. So a lot of times I would go to the hospital to talk to them about working and doing consulting work for the clinic. So I got my CCSP so that when I was talking to clients that were in the hospital side, they would recognize it at least, and so when I would be talking, depending on who I was talking to, I would change the credentials around in the way I listed them. So if I was talking to somebody who was truly all profi, I would list the CPC first and all my AAPC stuff, and then I'd list the HEMA stuff. When I would talk to the hospitals, I would list the HEMA stuff first, and and for me, that's what it was. It was about recognition. And for clients, and then when I kept going, depending on what I was doing, like if I was getting into like dermatology, that's one of my favorite things. So the CPCD, I was like, okay, now with dermatologists, I've had some clients that have said, oh, I see you have the CPCD, so that makes me feel more comfortable, blah, blah, blah. I am not a credential happy, I don't need 20 different credentials behind my name. I really don't want to ever take another exam if I don't have to. So, now it would have to be something super duper special for me to say, okay, I'll do another exam, but, so I don't necessarily think you need, 5, 10 different credentials behind your name. But you need a couple core credentials so that it's recognized. And then from there, I think your experience should, be able to speak for itself. But there are certain niches in our field where, I think it's helpful to have those specialty credentials for different things. But that's my take on the whole, how many do you need and which ones do you need kind of thing. Do you have any different, do you kind of feel the same way? Do you have any different takes on that?
No, I think your take on that is, it's pretty on point. I mean, you kind of notice, especially if you look, the different websites and so forth, you'll kind of see that, which credentials they'll list, in their little blurb, and, whether it's an AAPC one or it's an HEMA one, which one they're a little bit more preferable, treatment, and which one they like the best. But I do say that, having both, has probably opened a lot of doors that maybe just having one, so, but they're both, they have their good points and they have their bad points and so forth, just like any organization does and so forth. So, but I am like you kind of dread taking the test. I think when I took my RHIT exam and so forth, when I graduated and so forth, I'm like, okay, so let's schedule this and let me go take it. Did I study? No, I didn't study. I probably, in that span of 2 years of learning everything there is to take this test, I probably maybe remembered maybe 1%, because it was just so much crammed in a short amount of time and so forth. Mm-hmm. I just went and took the test and say, okay, well, we'll see what happens.
Yep.
Pass, but I'm like, whoo! But I'm like, whoo, that was 3 hours of I'll never get back in a day.
Well, and that's the other thing. Having a bazillion credentials doesn't really mean you can perform either, because it might just mean you're a good test taker. So, I mean, of credentials are important, but you also take the credential with a grain of salt too,
Yeah.
in my opinion, when I'm actually looking for people to help me with projects and things like that. If they have 8 million credentials, it's not like, oh, I have to have them just because of that, so I think it's those other things that go along with it. It might get you in the door, it might get you looked at, but it's what you actually can do. And many places now have employment exams. So you may have the CPC or the CCSP or the RHIA or T, and that might get you in, but they still may have their own exam that you have to pass, which kind of will moot the point of whether or not it's not about the credentials at that point. It's about actually what you know. And then, Angela, hey, Angela, she put out a good point about the CEUs, of course, and we have that issue. The more credentials you have, the more CEUs you have to earn, and, all of that kind of stuff. So, that kind of goes along with it. Now, some of us, though, like me, I could will my CEUs to my grandchildren if they would let us, accumulate them. But, that whole lifelong learner thing kind of plays into that, where I myself don't really have trouble with CEUs, but I do know what some of them, it's hard to find them for that specialty. Like the CERC for one with AAPC, there's only specific ones where you can get CEUs for that specialty and things like that. So, those are all things that you want to take into consideration when you're looking at the whole, should I try to add some more credentials to my name? Will that help me? I just look at the whole benefit thing, like, how is it going to benefit you and what's the benefit to it? Before you do it. That's just my, that's my 2 cents worth on that. But from a multi-specialty background thing, I think, back to that subject, I think it's helpful for people. As I said, I've had people come to me that have said, I want to learn about this different specialty. I think it's really interesting. I think it's really this. I think it's that. But I work at an office that is a different specialty, and, they, don't want to support anything for this other specialty because it doesn't benefit them. Well, I see that point. If I am at an ortho practice and my ortho coder comes to me and says, hey, I want to go to this dermatology conference, I would be like, okay, but if you want me to pay for it, what's in it for me? Kind of thing. Your employer is not really going to be benefiting from sending you there. So that's where I see people kind of sometimes get pigeonholed into a specialty. They may like the specialty, but then they find it hard to get out if they do want to do something else. And so looking at places, I think. Looking at multi-specialty clinics and things like that can be helpful at the beginning, to where you don't get in that rut, for lack of a better term, of the one specialty kind of thing where you're in there. Because I think that really enhances a person's ability in coding to have multi-specialty background, to be able to move around to different facilities, or in a facility, like if you work for a large health system and they have different specialties that are within that system, and they have an opening that comes up in cardiology, then you can say, hey, I've been doing this or studying that too, or I can do some of this, and can move into there. Or auditing. For auditing, it's very helpful to have that multi-specialty, experience behind you, because, you could be looking at a bunch of different specialties when you're doing an audit, depending on what you're doing. And, you really need to understand the particulars of that specialty. Ortho uses different abbreviations and different verbiage than endocrinology will use, or that a different specialty will use. So it's also helpful in that manner, to where it just kind of opens up, in my opinion, opens up more opportunity for people if they do have or are looking for multiple specialty background kind of stuff. do you think somebody with multi-specialty backgrounds, that they're going to have better outcomes when they're looking for things like that or looking at things like that?
I think they would. I mean, and I got to, going back and looking at my past and so forth. I mean, when I was a consultant and so forth, I didn't have the backing of a healthcare facility who would pay for, conferences. I mean, this was stuff that, had to come out of my pocket, and that could be very expensive, for anybody. But I think one thing that I did is I kind of went and, to the different American Academy of Surgeons or the American Academy of, I mean, I literally went to all these different websites and so forth and just kind of perused, what they had, what was going on, just to kind of keep me, number one, up to date. But also I would kind of, as my dad would say, in your little Googler machine, type in,
interweb.
Yeah, the Googler, type in, CPT codes for that particular specialty, just to kind of get, my feet wet and trying to learn. And I think it was more just me saying, okay, well, I don't have anybody that's going to pay for this. What am I going to do? Okay, I'm going to do it myself, and I mean, looking at stuff on the internet now, the information is just so readily available that, it doesn't cost anything, to find that information out. But I think having a multi-specialty background, especially, when you're auditing or you're coding, I mean, it's kind of interesting how, you kind of keep that stuff, in your brain, and, you might not use it all the time, but it's there and it will come back, when you get back and move to reviewing those particular specialties that you haven't looked at in a while. So,
like riding a bike.
It is. It's like riding the bike. And I think, there's nothing wrong with, like you said, knowing one specialty, but I think for me, I wanted to know more because why not, challenge myself a little bit. And I did turn it into a game with myself, see what I can learn, and so forth. But I think there's benefits, to being a multi-specialty coder or auditor and, sometimes being a singular specialty coder or auditor. So it really just all depends on what your career path is and what you want to do. So, but I guess, the big moral of the story, never stop learning,
Yeah.
I mean, that's something that nobody can ever take away from you.
Yeah, that's true.
I mean, it's the one thing that I think I've really appreciated about myself and learning with what we do. And it's the love of the field that we're in. I wouldn't trade it, going back and looking at how many years I've been in it, it's kind of crazy.
Yeah, I know. Now, if I know everybody has their favorite specialties, and those of y'all that watch or know me, know E&M, of course, but cardiology, dermatology, those are like some of my super favorites. If somebody is looking to say, okay, I want to try to get into like the multi-specialty, I want to kind of expand things from your perspective, from what you're seeing, because where you work, you get exposed to multiple different places in different areas of the country, right?
Yes. Yeah, I do.
So are there any specialties in particular that you see or think if somebody's looking to expand, like that would be a good one to get into? For me, I think, cardiology, of course, not just because I love it, but it's always a good one because it's, and for people that, I'm not meaning this in a bad way, but that would always be the one when I would do classes that after I was done teaching it, and I would be so excited when I would get to teach it. But after I was done with it, people would come up to me and either say, I just love that stuff. And where can I get more about it? Or they would say, I never want to see anything from in there again.
Yeah.
And they would do anything in their power never to look, you
Yeah.
know. And so I think that was kind of a polarizing one. But, you know, I think that's a good one because there is that where you just mention the name and a lot of people, especially interventional stuff, and people are just like, oh, no, sorry, no, not touching it. So I think that one's a good one just because of that perspective.
Yeah.
But are there any specialties that you think would be good for people to kind of spread out into from a marketability kind of standpoint?
Yeah, I mean, one that you know, the forefront that right now is radiation oncology. That's one area that, you know, is people don't. It's like you hate to read, you know, anything that has to do with cancer, whether it's in adults or children and so forth. But you know, those particular specialties are really in high demand. And really, you know, you kind of, depending on what facility, you know, you work at, or, you know, what hospital, you know, you kind of can get the idea of what specialty is kind of needed by, you know, you know, what your coders are what you're currently working on and so forth. But it's normally, it's the more complex specialties, like you said, you know, the interventional radiology, the radiation oncology, the cardiothoracic, your spine, your neurosurgery, you know. So, I mean, anything to do with the major organs seems to be the specialties that there's not a lot of people that tend to look at that, because number one, the coding is so complex. You know, and you have so many different CPT codes and stuff that you have to worry about. But there's a lot of resources out there that my OneNote for work is just overflowing with all these different websites I go to find information and so forth. But I'd say those are probably the biggest multi-specialty that I see that people need coders or auditors for, just because there's not that much experience. And it's like I said, you're not going to see it in a small facility, but in your big teaching facilities, that's where you see that.
Yeah. And I think also too, sometimes it might not be the actual coding itself, but it's all of that back stuff about the regulations and the LCDs and the NCDs and the, you know, so something may only have a couple codes to it, you know, but it's all the other stuff that goes along with it, and the documentation sometimes, you know, especially with ortho stuff, where it's like you have to document that they tried this and they failed that, and they did this and they did that, and all of it. So it's that kind of stuff. So it's not necessarily the code itself, it's all the stuff that goes with it sometimes that, you know, is a hassle for people. So until you get used to it, and then once you're in it, then it's a lot easier to pick out of what things are necessary and what has to go with what and all that kind of stuff. But I think sometimes that is where some other people will say, oh, that's such a headache to do, blah, blah, you know, kind of thing. Now, John put general surgery, he threw that out there. And I think general surgery is a good one because they do a little bit of everything. You know, you got some GI, you got some, sometimes the simple mastectomy stuff, you got, you know, so you kind of jump around into different areas when you look at general surgery. So I think general surgery is a good one too, to be looking at, because it's that, if you've got that interest of wanting to see different stuff, general surgery is probably a good one. A lot of hernia repairs and, you know, different things like that. So they can kind of jump into different areas when you're looking at general surgery. So you kind of have to have that, oh, now I'm, you know, looking at the GI, or now I'm in the skin, and then now I'm over here. And, you know, so that would be one where somebody would need to have that broader area, or that thinking outside of that pigeonholed set of CPT codes, or, you know, like my section of CPT is the 20,000s, or I'm the 40,000, you know. With general surgery, you're kind of get all over the place. So I think that's a really good one, John.
Yeah, brain surgery too. I see a lot of interest in that too, because like you said, they do everything.
Mm-hmm. Now, what challenges do you think, and have you had when you've worked across different specialties? Is it more on the operational side, or for you and getting into it and saying, okay, well, today I'm in GI, and tomorrow I'm going to be in ortho? I from a person that's looking at, again, expanding kind of things, like, what are things that were difficult for you?
I think, sometimes, especially if you look at the office setting and so forth, and, the physicians will have their own tests that, they automatically do and so forth, that, OB, they're going to do a UA and so forth. And so you got to remember, to bill for that. Or if you're doing ortho, they're might do an x-ray or whatever the case may be. And I think that in itself, when you haven't done it for a while and you're like, oh my God, and you have to say, okay, what is the normal, standard of care, for that particular specialty and so forth. I think that's probably one of my biggest challenges, is trying to remember all the intricate details, and so forth. And I tell you, I derm. I know you love derm, but I do not like dermatology, especially when you're dealing with flaps and you're dealing with, that just, I sit there and I can stare at, an operative report for an hour. I have no clue, that's just because it's the area, it's that one specialty I don't like to do,
Yeah.
Well, you dread it, but you get through it. But yeah, there's definitely challenges, and just kind of remembering all that stuff, because like you said, there's so much information that we have in this field, and it's hard to kind of keep track of it all. And I do to this day kind of keep a little cheat sheets, of different things that the different specialties will do, just to remind me, because I forget. Especially if I'm talking with a coder who might be doing derm, and she said, well, what about this? I'm like, oh yes, you're right.
Yeah.
She's in there all day long,
Yeah.
she sees it. She's going to know what to pick up on, what to bill, and all this good stuff. And I'd be like, oh yeah, and you kind of close your eye and you bang your head, but that's, you appreciate the people that work in those specialties day in, day out. Because, it really is. It's just fascinating that we can remember those intricate details for a specific specialty and stuff. But challenges, they come every day. But you just kind of wiggle your way through it, and you'll be okay.
Yes, and we don't call them cheat sheets, Sally. They are job aids.
Oh yes, yes.
Remember? Yes, they're job aids.
Yeah, they still have cheat sheets.
And that's the thing for somebody that's even in one specialty. If they work in just one specialty, I think one of the bigger challenges, as I was saying before, is not necessarily the coding. It's the regulations that change, and all of the other things that change, and the technology, of course, as we're getting into different things where they're coming out with new ways. They have a new, now I have one client that I think has used it on one or two patients. There's the new way that they have for treating some skin cancers with these treatments instead of excisions and things. And there's new ways that they can do biopsies now with these little patchy things that they put on, and that like takes off, there's just weird stuff that comes up, and then it's just like, okay, how do you code for that? Like, what would that be considered? Stuff like that you have to figure out for the specialty. And so I think for people that are multi-specialty, that's something that you have to also consider, in that you do have to keep an eye on a whole lot of stuff that, is over and above what somebody sometimes that's in one specific specialty may have to do. So it's learning ways to be able to do that. Are there certain sites or certain organizations or things that you use to help you with watching for those things and staying up on them?
Yeah, I mean, you know, there's an article or one that I kind of tend to go to is called Urology Today. And it kind of gives it's these two physicians, and they write an article and they kind of keep you up to date on new different procedures that are happening in urology. So I try to go and find, websites like that, that like Dr. Z, I go and see his little answered questions, or I go to Becker's and read that information. So I go to all these different websites and so forth, and it doesn't matter whether it's geared toward inpatient or outpatient or prophy. I look at all of them because you really want to be up on top of your game, because healthcare is changing every single day, like you said, and the new ins and outs of different medication and even treatments that are coming out and so forth, or just, you kind of sit there and you're like, yeah, what is the code for that? And there isn't a code because it hasn't been done before. I mean, and, I think there was I think a couple months ago, I had to do a surgery. And it was one of those surgery that I know that can cause, complications, people might not necessarily like to hear. And it was about the gender reassignment surgeries.
Mm-hmm.
And, so it was like, I don't know how to do that, and somebody asked me and I'm like, I don't know. And nobody really knew. And you just had to go and find, okay, somebody has got to have written an article about it. And they did.
Mm-hmm.
And that was the only guideline that I had to really look to see what codes I needed to use, and so, it's, some of them are the unlisted codes,
Right.
because it's not out there yet. So I think that in itself can be challenging when things are new and there isn't a code for it yet. So it kind of makes it more difficult, especially when you need to bill it, to insurance for, doctor and whatnot, so they can receive their credit. But you do the best that you can with the information that you have.
Yeah.
But
yeah, it was a lot easier. Well, a lot of things were a lot easier when I first started. But when I was at the IAHEMA conference, I was talking to the group in one of my presentations, and I told them that when I first started out, we could send claims out that had the CPT code with no ICD. It was not 9 back then. We had just gone to ICD-9. We could send them with no ICD-9 codes on them, and we'd still get paid because it wasn't required. You didn't have to have it. So, and I didn't think it was right to put down a diagnosis that I wasn't sure that's what the patient had. So that was always, a nice out for us back then. Also in CPT, it used to say in CPT in the guidelines that if the CPT code is not specific to what you're looking for, if you can't find a code for what you did, pick the closest code and report that.
Mm-hmm.
So it was just like, okay, well, that's pretty close. Yeah. So we'll go ahead and use that one. But now, of course, they do not say that any longer. Now they tell us it has to be everything in there, or you have to be able to use it with a modifier to do it right, or you have to use the unlisted code, so it was a lot back then because it wasn't so heavily regulated, and everybody looking at every single thing you do every time you turn around. And, it was just, you did a service, you put you put a CPT code on it. And if you knew an ICD-9 code, you could put that on there too. And, you'd send the claim off and you get paid. But now everything is so super scrutinized, that it is a lot more intricate, and complicated and complex for what we on that side, in the healthcare field, what we're doing. I think, my big ones would be, always, of course, CMS to, whatever your MAC is, go to your MAC and you can be, you can get on their mailing list. So when they put things out, you'll get notices. And I wouldn't just do it, especially if you're doing multi-specialty consulting kind of thing. You will want to go to every MAC and get on every MAC's list, because, what Novitas says you can do, maybe First Coast says, no, you can't, so you'll also want to be taking those things into consideration, depending on what region of the country you may be working on as a consultant. Because you could be jumping from state to state, depending on the jobs you're doing. So every MAC could say something different about something. So, go to the specialty society, is another place I would say, because usually they'll have sections in their websites where they do give advice and have articles from other physicians and APPs about certain things. That could be a good resource. And again, with Angela, can't agree with you more, Angela. Hours and hours and hours of research on some things. Yes, you just sometimes just kind of have to dig and see what you can come up with. And then of course, whoever your big commercial payors are, for wherever you happen to be, be looking at their medical review policies and things like that, and try to, keep those in your head. The AMA has been putting out, they have that, I don't know if they call it the research hub or the educational hub, but the AMA has they'll put out things for that, where it gives you advice and things like that. For ICD-10 stuff, the coding clinic, would be my go-to if I was looking for something that I could, put a stamp on and say, here, it says it here. So that's what we're doing. I'm not going to question it because coding clinic says so. Same thing with CPT. If you can find something from the AMA from CPT assistant, this is what it says. You just have to make sure, if you're using those resources, that they are updated. Because I've had people before come to me with something. Well, I have this CPT assistant article that says you can do this. And I look at it and the article is from 2014. And I'm like, well, yes, back then it was okay. But if you look, they've also put out 2 more articles that are more recent than that, saying that, no, the guidelines changed. And so you can't do that anymore. So make sure that it's relevant to what you're looking for. But I think if you were going to give advice to somebody who's saying, hey, I this multi-specialty thing is kind of, I think it would be interesting for me. It would make it interesting for me to be in this long term. I like all the stuff that, I've heard today. What places or what things would you say they could use to, what would they want to do to expand into those other knowledge bases?
Well, I think if you're interested in doing that, go for it. Search it out. Ask questions. I am the biggest believer in asking questions to anybody, and also networking with other people, from different facilities and so forth. That really helps too, because you're not always doing the same thing that everybody else is doing. And I think just anything and everything to do your own research, explore, expand your horizons or whatnot, if you want to. If not, that's okay too. So, I mean, derm is not for everybody.
All right, quit knocking derm.
But it's still, you go and you find the answers, or somebody who knows the answer. That's what I like. I know that if I have a really complex derm question, I can say, okay, what do you think? I know that you're going to give me the best resource of how to code or review or whatnot. I know that I have that out there. So that is, I think that's the best advice I can give is just, the people that you are surround yourself with in your field is your great resource from day to day.
Yeah, and I think a good thing, a great thing about our field is that most of us are willing to, generously share that information when we have it.
Yeah.
It's not that I know this and nobody else can know it because then I'm not special. We really are a community, and one that is very willing to help each other out most of the time. I think your component associations, if you're an AHIMA person, your AAPC local chapters, if you're on that side, those are great places to, look for educational kind of stuff on different specialties. Looking at places on, LinkedIn and, the emails you get, there's a lot of places that give free webinars and education on different things. So, attend something that you don't have to pay for another specialty when they're doing a webinar for it, and see if you think it's interesting and you like it. BC Advantage is that magazine, and they have webinars. They have a bajillion. I've done a ton of them for them, so they have a bajillion webinars. That if you are a member of BC Advantage, for I think it's like $75 or $85 for a year, you can listen to every webinar in their library, and you get CEUs for it too. You can get a whole different set of things that you can go and look and listen to, kind of test that out to see what your interest may be, or to get information on specific things. So that's one thing I think is good for us nowadays, is that because of COVID and what it did, where you didn't have to or couldn't go to in-person stuff anymore, that there's a lot of stuff that we can get virtually, and you can find a lot of stuff from all over the country that maybe you weren't able to be exposed to before. And Angela, again, yes, is bringing up a good point that, the MACs, they're great resources too. That's why I said, you want to sign up for those MACs, and they'll send you when they're having, their educations that they put out there. And you can get CEUs from those too. And those you don't have to pay for when you do those. So there's a lot of things where you can get that good information from that's not going to cost you out of pocket to do. So just kind of spread out, check everything out. Go on, if you're on LinkedIn or on Facebook, look for people that are in specialties that, you like or that you're interested in, message them. Read their posts, look at what they're doing, for stuff that they're putting out about those specialties. John, who is with us today, John Piaskowski, he has his broadcast of the Coding Cheerleader, and I think he likes to put out different areas and, does them from different perspectives, so that, people can kind of like see it through which way it goes, and what they want to do. So I think that's a great thing. There's a lot of people that do LinkedIn Live, Christine Hall, so there's a lot of us out there that put things out that you can get that information from, and learn about different things that you might be interested in or want to dig more into. They're out there. You just have to, go and do a little looking for them. So we are at the top of the hour. We've already spent an hour talking about this stuff, which I love. So thank you, Sally, for being with me today, this afternoon. And thanks to everybody that was listening for the past hour. The next session I have, I'm really excited. I got my friend Pam Vanderbilt, and she is going to come back on, and we are going to discuss the revenue cycle, because we have a mutual client, and she found out during a call with them that they didn't know what the revenue cycle was in the manner of what it all entailed. that she's like, no, it's not just the billing. They were like, well, that's just billing. No, it's not. It's your front desk. It's the documentation the physicians are doing. It's all of the things that go into the revenue cycle that they really didn't have a clue to. So we're going to have a discussion that goes through and talks about the entire revenue cycle, that it's not just billing, and all the factors in the practice that affect the revenue cycle for revenue cycle management. So that should be a really cool discussion too. So thanks y'all. Tomorrow will be the actual Friday, not baby Friday. So enjoy tomorrow and your weekend. Sal, any parting words before we sign off?
No, thank you so much for having me. This was so much fun. I really did enjoy it. And, I would just say to all your audience, reach for the stars,
You're so wonderful. I just love being around you, Sal. I always have. So thank you, dear. Okay, y'all. Well, we will see you next time so that we can talk about what is happening in healthcare. So till then, everybody have a wonderful weekend, and we'll see you.